Okay, good afternoon. Are you ready for the home stretch? Yes? What a wonderful, wonderful time we've had the last 2 days. And I know that if you are like me, you feel energized and motivated and inspired, and many more words that can hardly describe the excitement that I have experienced. Let me introduce myself. For this afternoon, I'm your convener. My name is Ans Van Erp. I'm one of the committee members. And in my everyday life, I am the director of the Cunningham Center. And you may have perhaps already enjoyed some of the presentations from the Cunningham Center staff. The Cunningham Center is a training organization, and we develop a lot of training for rural doctors, most notably the Rural Generalist Doctor Program, rural nurses, and rural allied health. But this afternoon is not about the Cunningham Center, it's not about me. It is actually about continuing to give back to the audience. For those of you who have traveled from faraway distances and not so far away distances to come and to learn and to be inspired and to be motivated. So to actually give a really nice way to rounding up here, I'm going to invite, we are going to have a Q&A session, and we are going to invite 3 speakers. After that, we will hear from Dr. Jeanette Young, who has traveled to join us to close the conference and to provide us with some information. And Dr. Young has already kindly offered to answer some questions, should you have any. And then after that, we are really going to wind it up and wrap it up and have some closing remarks. And then at the end, of course, our esteemed convener who will bring it all together. But first things first, we are going to invite 3 of our speakers. We've heard yesterday from Anne and Poppy, and today from Dr. Dan. And I know that you may not have had the opportunity to hear all 3 of them, for those of you who have only joined today. So really to give you another opportunity to hear more about these exciting initiatives that these people, these 3 champions are leading, I invite to the stage Anne, Poppy, and Dr. Dan Manahan. Please join me in welcoming them. Just to give you a little bit more of an idea, clearly it is not an unusual way to end conferences with Q&A sessions. And really the questions are yours. This is really the opportunity for you to ask questions and to have the answers. We've set aside 45 minutes for that session. And it might well be that we don't need all that time, but we certainly didn't want to cut in, because some of the presentations, as you may already have experienced, didn't allow for questions to be asked. And it was because the presentations were so engaging. You know, we always, when we did the planning, allow for question time, but sometimes the presentations are so good that you just don't want to ask for time to be taken aside for questions. So we now create this opportunity here for you this afternoon, okay? Now, I'm going to, as a convener, I actually may have that privilege. So start thinking of your questions, and if you have a question, just raise your hand. But given that I have the microphone now, I will actually ask the first question. And I actually probably have to do something else before I do so, because as I said yesterday, we had the keynotes and you've probably seen their biographies or you may have heard about them. But as a matter of courtesy for those who were not here yesterday, I will ask each of the 3 panel members to give a very brief 1 to 2 minute introduction about themselves so that you all get to know them. And may I start with you, Anne?
Oh dear. Hello everyone who missed me yesterday. I've got a copy of my speech here if you'd like it. I'm Lambert from the nation's capital and here to help you. I have worked in the health system for more than 30 years, lastly as Chief Executive of Women's Hospitals Australasia and Children's Hospitals Australasia based in Canberra, having worked in a range of women's hospitals in Victoria and elsewhere. But then I developed a lethal illness and had to give up work and dragged an oxygen machine around for about 12 years. I have a condition called fibrosing alveolitis, and so I got to observe lots of things that were terrific in the health system and not so terrific, and have been used by governments variously as a consumer advocate and a troubleshooter and so forth. I think that summarises it.
Thank you. If you mind passing the microphone on to Poppy.
Hi, I'm Poppy Malone. I take care of the community engagement and community support team at Higher Up. So I presented yesterday on Higher Up, which is an online platform that gives Australians with disability the power to find, hire and manage their own support workers. So slightly different kind of concept to the telehealth, but I think all very relevant in terms of where technology is taking us and how it's challenging service provision that's sort of always existed and the opportunities that it brings. So yeah, that's...
Thank you, Poppy. Dan.
Dan Manahan. I live in Stanthorpe, just down the road, 2 hours. And I'm currently the Director of Medical Services for Darling Downs HHS's Rural Division. Prior to this role, I was the Rural Generalist Medical Director for most of the first 10 years of the program, and the Med Super at Stanthorpe for 20 years. And I'm a clinician, and I'm I think someone used a sausage in the ear, sausage meat in the ear analogy the other day, and I feel a little bit like a fish out of water in a manager's skin at the moment. So I've gone into a management role, and I'm really enjoying getting around the Darling Downs, 17 hospitals about the size of Austria, and meeting with all the clinical teams, which are doing a great job and looking at the wonderful challenges ahead, including telehealth.
Thank you for that, Dan. As I've said before, I have the microphone, so therefore I'm going to ask the first question. And I'm going to start with Poppy. Yesterday, Poppy shared with us some information about Higher Up. She's a community engagement manager at Higher Up, which is this online platform that connects, as we've just heard, people with disability and support workers. And one of the things that I wanted to ask Poppy is to fast forward and take us to 2020, or perhaps even beyond, and tell us a little bit more about what the world of disability support could look like.
Thank you for your question. Great question. Well, by 2020, I guess to start off with, the NDIS will have fully rolled out across the country. So I get very, very excited thinking about what 2020 will look like. But specifically for Higher Up, I think, and I've already had a lot of conversations with people here around how this platform can also translate into other sectors. You know, probably the next sector that we would love to launch into is the aged care sector. You know, there's a huge amount of parallels with, you know, how services can be provided and how families can have more choice and control over the supports that maybe their you know, elderly parents are receiving. So, you know, in 5 years' time, which actually will come around very quickly, I guess I imagine that Higher Up will be in a whole bunch of other fields, things like allied health, aged care, mental health, providing supports in a really flexible, tailored way. So that's going to be quite a big challenge for us, because just sort of tackling the disability sector and the awards and all of those sorts of things is quite complex. So to think about sort of going into allied health and having a platform where people can connect with, you know, casual speechies and physios and all the rest will be really interesting for us. So yeah, 5 years' time, that's maybe where we'll be. I guess I'd love to see that we become, you know, a really, you know, a brand that everyone just knows of, and that we're really encouraging other service providers to think differently around the provision of supports like this, and really challenging the status quo. So,
Thank you.
yeah, that's where I would think I would see us.
Well, you know, the reason why I felt inspired to ask this question is because out of session, and I think it was yesterday, Poppy and I had a conversation, and she really struck me as somebody who is thinking forward all the time and has big posters and little sticky notes everywhere, thinking what she's going to do next week, next month, next year, and I thought that is really a symptom, really, if I can use that word, of the way in which we for the last 2 days have been thinking. It's not about the past, it's about looking forward. What is it that we can do and not be faced by some of the challenges and some of the barriers? My next question is for Anne, and I guess I was particularly intrigued by Anne's yesterday's presentation by her condition, a rare condition, fibrosing alveolitis, and as a physio I googled it and quickly found out that she actually has a nickname, which intrigued me, and you may already have picked on that, but I definitely want to hear more about this. Oxygen Woman, tell me more about this.
So it bothers me, Ants, that you did a Dr. Google.
I followed your example.
Good on you. Good on you. You've learnt something from me.
I did.
So when I became ill, I became shorter and shorter of breath and needed to be on oxygen permanently. That's the trajectory of this illness just before you die. And I discovered that oxygen is not, believe it or not, a free commodity. And 1 year I decided, well, if I'm going to cark it, I might as well spend my superannuation because I'm not going to need it. And that was $30,000 that I spent on oxygen 1 year. And having spent that, I knew it was unsustainable. In the meantime, I had, because I worked in the health system, I knew how it worked. So I went to the health fund and they told me to disappear. I went to the ACT government and disappear as well, and the federal government was the same. Now this intrigued me. I'm a lifetime non-smoker, so I hadn't caused my illness. Not that value judgments should be made, but they were. Value judgments are made about people with lung conditions that they've smoked themselves into an oxygen machine. We don't make value judgments about people who have drunk themselves into a motor vehicle accident. We fix them up and make sure, they might be charged, whatever, but we fix them up. We don't make value judgments about that yet. I think oxygen is quite a difficult thing, and so value judgments are made. You've got yourself into this predicament, that's that. So eventually I was able to convince our own government that they should provide oxygen, and initially that was capped so that you could go to the doctor each month or whatever. Well, as I said yesterday, I had a little boy, and this good-looking husband, who I should describe as my first husband, on the prowl for the next one. I actually wanted to do things more than just go to the doctor, oddly enough. I ride my bike about 80-odd Ks each week around Canberra's beautiful bikeways and so forth. So I was able to convince the government that there were a set of circumstances for a whole heap of people so that they should have uncapped and free oxygen, and that exists at the moment. And New South Wales is the worst state. Sorry if you're from New South Wales. They won't provide it at all, or will provide a very little bit. But different states are now doing different things and using the technology, the machines that you can buy now that you didn't used to be able to do. You had to have it in a bottle, which is very unfriendly if you want to travel and so forth. So in the end, I had a machine that plugged into the wall and I could charge batteries up and so forth. So that's why I'm called the Oxygen Lady.
I love that explanation. Thank you. And another quality that actually Dan shares with Anne is that he too really doesn't take no for an answer. Dan has worked with the Cunningham Centre in a previous life and developed the rural generalist model. He's together with Dr. Dennis Lennox, the architect. And one of the things that I really admire in Dr. Dan Manahan is the ability to juggle some of the clinical decisions that he has to make, just it's life and death, make the decision very quickly. And on the other hand, when he's an administrator and there's red tape and there's bureaucracy and there's lengthy times that before the decision is made. Now, this morning, we heard from Dr. Williams from Canada how advanced they are. We also know that in Queensland, we thought we were We actually are very advanced with regard to telehealth. But when you see examples from other parts of the world, you think, oh yeah, I want to aspire to be that. And I'm going to use the analogy that you use, Shane. We are a Beetle compared with the Ferrari that they have in Canada. And my question to Dr. Dan is this afternoon, how can we make that Beetle, our Beetle, into a Ferrari?
Thanks, Ans. I guess the first thing is, why would you want to? But, you know, I'm sure there's a room full of Beetle fans out there. Some of the things that have happened in the experience of the Rural Generalist Pathway were an alignment of the stars. And I know that everybody has shared experiences of telehealth. And one of the comments from yesterday was, choose your own telehealth adventure. And I think that really does hone in on the use of clinical champions, of passionate consumers, and when they match, you can actually get a really good product. But it ends up being niche market in different areas. And sometimes, as we've seen with telestroke talk that we heard this morning from Matt, that will then lead to a rollout. So that's, again, an alignment of the stars. But the other thing that's necessary is that buy-in, and we've heard this through the conference as well, from all levels. So you need that buy-in from the top hierarchy, and clearly the Queensland Department of Health has bought into the telehealth agenda with the various departments that are supportive of it, some of the incentive payments and the like. And each of the presentations that have come from the various regions of the state have shown how there's buy-in as well. That buy-in has to filter right down to the coalface. So some of the issues that I've experienced in my conversations with both hospital and general practice doctors who are in my world, in rural world for me, usually the recipients, that they're not certain about the funding programs, the funding opportunities. They're not sure about the longevity of the current funding models. They're not sure if what's available is going to actually help them to help patients or work with patients and actually have a business model that pays the bills as well. So that uncertainty, I think if we can get some certainty around those processes, I think that will make a big contribution at the grassroots level. And the other thing is the consumer driving the process as well. So I've certainly seen some dramatic consumer-driven processes in my roles. And in one in particular was the mums group in Stanthorpe, the Mothers for an Updated Maternity Service in Stanthorpe, who worked very passionately to turn a really good functioning clinical unit into one where there was some infrastructure through a variety of lobbying techniques. So when you line all of those things up, you can do something special. I guess the other thing is, a lot of it's a bit like being in a Dodgem car circuit. You know, there's a lot of bump and thrust going on, lots of different things. We heard from Janine's the last talk in this room this morning about some of the bump and thrust about turf wars and how they can be really minor things that interfere with an outcome, and how you've got to spend so much wasted energy doing workarounds for those kind of things. So just smoothing out and greying the barriers. Another thing that Ewan spoke about as well was greying the barriers between the various sections, between private and public, between HHSs, PHNs and HHSs. I think that'll be a theme over the next few years in the 2020 discussion. I think seeing those greying of the barriers will be really important.
Yeah, go
to
ahead.
that.
Yeah.
I think what you're really saying, Dan, is that the governance has got to be right. And so often, you know, some of the things we heard about this morning in this room, they're fabulous, fabulous projects, but you've got to get the governance right at the outset. As I said yesterday, if the governance is wrong, it is the root of all evil in the end. And you've got to think the whole project through and not piecemeal, I think.
The responses that we've had to these three questions really show the collective wisdom that sits at this table. And I am now going to open it up to those of you in the audience. And we have some microphones going around. So please raise your hand and we might take the first question. Yep. Do you have a microphone there? Or
yeah, I've got a microphone here, yeah.
Go ahead.
And being a passionate advocate for the consumer, you've been here for the 2 days, you've listened to a lot of keynote speakers, you've listened to a lot of presenters. How are we going with the consumer since you've heard, the last 2 days' presentations?
I think Queensland is miles ahead, actually. I've been quite pleased. I think with some of the projects, when you hit those road bumps, you can use your consumers to go and talk to the radio station or the politician, which is how I got oxygen. I had a good friend, Chris Ullman, actually helped me from the ABC get that oxygen, and I couldn't have done it without him. And in the end, his mum and dad both needed oxygen as well. So it was a two-way street, I guess, just before they died. But I think as one of my finishing lines yesterday was, your patients are your greatest advocates, and you've got to use them. They will knock down those IT barriers for you by just having a bit of a chat quietly to Jeanette or other CEOs or to the radio, as I say. And I think keep using them, keep embedding them in your programs in the way that you have already. You've thought about them already. You've done a great job, I think. So I'm impressed. I should mention, I think I mentioned it to you, Shane. After the Canadian talk this morning, there was and you wouldn't have seen the tweet because you probably wouldn't have. And I mean that in a kind and caring way.
I have tweeted twice this week.
There was a tweet the other day from someone saying their little son had said, "Oh, Mummy, what's a Canadian?" And Mum said it's a North American without guns but with a really good health system.
Oh, I like that.
Good afternoon, panel. Ashley Perring I'm the Director of Nursing out at Miles, so about 160 k's this side of Roma. From looking where we've come in the last 2 years, from 2 years ago when we were here, was very focused on the digital divide, and especially around the outer rim of Miles going through to Tara. There are no phone services. It's very patchy, it's very limited. So the digital divide that's actually occurring with the people out there with chronic disease, they are so at risk of slipping away. But I'm looking at the other side. We've just had an amazing program rolled out into our primary school offering speech pathology. And that's offering from both Brisbane and Sydney, and the kids are just coming ahead in leaps and bounds. Is this digital divide that's out there at the moment only going to be there for the amount of time for the people that aren't digitally ready for that? Is that something that's going to disappear? Dan?
So I think looking at the talks I've been to, Ashley, over the last 2 days, I think one of the themes for me has been that we're still relatively engaged in provider to recipient services that are predominantly with a health service provider in a rural location. There have been a few discussions about direct to home, but some of the key issues around that have been funding models about direct to home, and others about consumer readiness for direct to home. So I actually think that consumer is more ready for direct to home. That's my personal view, but there seems to be a clinical view that that's not the case, and I think that needs further analysis. While we're still going provider specialist service in regional and tertiary to clinician service, I don't think that the impact of the lack of digital readiness in some of those more remote locations is the issue myself. I think because they're going to be coming to services that do have internet readiness, I think that the service can be provided from those locations. The real problem will be the parallel movement, I think, of the digital network in those locations as we roll out provider into the home, provider to the consumer direct. And as that matures, I think we're going to be in strife if we don't get the digital side ready in advance of that.
I don't know if you saw this morning that Minister Fifield, the Minister for Communications, has put out a press release and presumably the accompanying tender for the 000 service. Did you see that? I think that sort of thing might make a difference. But the other thing I just wonder, I'm just wondering about the outcome of this conference. Is it planned that you will have a set of best practice identified as a result of this that you might send around to people like Telstra, the Minister for Communications? I mean, obviously you'd do it locally with the state government, but I just wonder whether that's been a thought and something you might do.
Yeah, certainly the facilitation of sharing is one of the focuses of this conference, and sharing of not only information but also sharing of best practice. And the recommendation that you just put on the table is certainly something that could be an outcome that the committee will take further, that this particular 2 days really has resulted in actually change, and not only communicating that back to our workplaces but also with other stakeholders such as Telstra. Very good.
And I just wonder if too, with Ashley's question, that with Poppy and Anne, do we give the consumer enough credit with their technically savvy? Because a lot of them are. You're working in the disability industry. A lot of aged care people there. So I think we've got to be very, very careful that we've got to give the consumer a lot more credit than I think that they're not getting at the moment.
Absolutely. In my experience working previously to this role in a very large service provider, and having known that Higher Up was a business that was rapidly growing, the fear amongst large service providers around these digital solutions, the fear that they will be very much threatened. Their existing business model was getting threatened, and the immediate response is, yeah, but our clients or our customers can't do that. They wouldn't be able to do that, and they'll continue to need us. Now that's only going to last, so far. Maybe it might last a couple of years until, or if that, moving over to Higher Up. What we've found is those people that large service providers or people have said that they wouldn't be capable of managing a device or using the internet to book services, and it's a very, very simple platform that we've got. We've actually found that all of those people can. It might be a bit of a conversation over the phone to get them started, but actually people are incredibly capable of managing, using platforms like that. So, yeah, definitely need to give people more credit.
I agree. My mother's just died about 2 weeks ago, but aged 89, but about 12 weeks ago we taught her how to use a tablet so she could watch Carlton lose every week. And she was focused on that. She got it going, and I think we assume our patients are dills unfairly. They'll work it out, or we need to make it easy for them to work it out.
Yeah, and actually, I want to add a personal story to that. My family lives in Holland. That was where I'm originally from. But my mother lives in Holland, and in her neighborhood, 5 years ago, they introduced a small pilot. And she and several elderly were selected to be included in this pilot. And they were given an iPad. And with the iPad came instructions, and they had to do basic things like learn internet banking, learn having a Skype conversation with the GP, send an email, which she proudly did, and then rang me in the middle of the night. She forgets the time difference to say, "Did you get my email? I sent you an email." And now, fast forward, my mother turned 85, and she asked for her birthday. And actually, I should really say that after the pilot, which was about 6 months, they asked the residents, or they asked the participants, whether you want to return the pilot or keep the pilot and buy the pilot, buy the iPad. And they all bought it. And in fact, when my mother turned 85, not that long ago, she asked for the iPad 2, or an iPad Air, I think it was, because she is very competent now and is on Facebook. And she asked about Snapchat, but we say, no, Mum, not Snapchat. Not Snapchat. All right. Okay, let's just go for another question, please.
I've got one for Dan.
Yeah, go ahead.
Here. I know you're passionate about medical supervision via video conferencing in our rural and remote sites, looking after our junior medical officers, to ensure a safe clinical environment. What's your thoughts for the future on a future model in this space?
Yeah, thanks, Carrie. The medical workforce rurally is growing, so notwithstanding a few black holes that need to be filled, but we're still seeing a junior relief pool that goes out to remote locations, and and we're trying to build up supervision models that are really strong for them. And we've had a relatively unregulated market in that space until recent times. So we're looking at distance modelling and things like that. So the supervision won't necessarily be by someone who's in the building with you all the time in some of these really small country towns. And the thing about Australian doctors is they're really well trained. So, you know, the training we give our doctors in acute care for the ED side of things is second to none in the world, really. And the thing the junior doctors get really pent up about is Mrs. Smith, who just needed a blood pressure and heart failure treatment tweaked in the clinic, you know, and they just don't have that experience. So we've done just ad hoc work with some of the junior relievers, just doing some FaceTime work, face-to-face at the end of the evenings to run through how'd your day go, list off a few of the cases they want to talk, so just tell us what happened and what do you think and did I do a good job. And the level of engagement from what was probably, you know, I've got a piece of paper with the doctor's name on it that I can call if I've got a problem, so relatively cold and distant, to a phone call, a FaceTime, and then a catch-up each day or second day. The level of confidence that flows from that interaction is just amazing. And it really turns around an experience, a rural experience for a lot of these juniors that I've worked with this year. And I think that is the way that we'll go forward.
Yep. I acknowledge that, being a rural clinician, knowing the value of having the support for your junior doctor. I guess clinicians in the room will know when you're Johnny on the spot as the nurse looking after a junior doctor, it's a big responsibility as the rural director of nursing or a senior nurse. So knowing that that support program is available to grow the workforce is fantastic. Thank you.
Thank you. We have. I'm just looking at the time. I think we have time for one, perhaps two more questions, and then we have to wrap it up.
Can I ask Dan one? Would
Yes, of course.
Would you ever... You didn't pay me enough, darling. Would you ever think of letting those junior doctors email those patients at the end of the shift to find out, you know, the ones they've discharged, to find out how they've gone, just to make sure they've got their diagnosis right, or their... Do you think that day is coming?
Yeah, well, I guess the feedback loop is what you're describing, and that last wing of the feedback loop. I haven't really thought about that follow-up mechanism to go back to them, but I know that would be something that was really warmly accepted by the relieving doctor if the guy who's in the position comes back, looks at the list and then gives them some feedback about the outcomes. That'd be nice. We are still struggling to get feedback about the patients we send out in helicopters, so the feedback loops have always, the last limb of the loop is always the one that we're struggling to fill, but I think it would be wonderful. Yeah.
Can I just make a comment on that note, Anne? We are doing discharge telephone calls for patients who have been an inpatient, and part of the conversation is, you know, have you made a follow-up appointment with your doctor? Have you got your prescription filled? You made that comment yesterday, Anne, about people, you know, finding scripts in the hedge at the front of the GP practice. So I guess that's a little step towards closing that loop.
You don't fax the reports.
Absolutely not.
Kerry, can I just ask out of curiosity, is that for all the patients that are discharged or only those that go to rural and remote?
We would like to, I mean, ultimately it's a huge job, but we have started in the rural space in the Darling Downs, trying to offer a discharge phone call to a patient that has been an inpatient, just to ensure that they're safe and well and everything's lining up for them and getting some, and the feedback is very positive from consumers.
All right, okay. Any closing comments? Looking at the time, we have 3 more minutes. No? Can I then ask, if there are no further questions, ask the audience to please join. Oh, sorry, there is. Sorry, I didn't see that. Kerry, just gonna get this. Sorry, thank you. I'll take that question.
Thanks, Savannah. Just a quick question. This one's for Anne. I'm remembering your comment in your talk the other day, which was very good, thank you, about the My Health record, or what was called the PCHR, and how you found that not very useful for you. Can I ask, from your point of view as a community member, we're talking about at this teleconference how the sharing of information is so important and how lacking it is, and we don't get that feedback and that consistency of care. How do we make something like that work for community? What's your opinion about how we get something like that to work better?
My record from the Alfred in Melbourne, St Vincent's in Sydney, the Canberra Hospital and my GP needs to be on that record. Yep. The entire thing that I can access, and so can everyone else who's authorised to access, probably not you. So, I mean, I thought that was the whole aim of the exercise, frankly, and it still puzzles me that in this day and age, as I said yesterday, when my bank is secure, the tax system is secure, perhaps the Bureau of Statistics not so much, but anyway, that's another, maybe they should have looked at the bank and the tax office, but these are basic things, so that, I mean, I've lain in emergency departments listening to emergency physicians trying to untangle an elderly person's health status through a nursing home, through a GP, through other healthcare providers, and it's not a happy hunting ground, and it's not a happy outcome for the patient without that information. And then there are the repetitive tests that are done. Oh, you had blood done last week, but that was at the private facility and it's not here and it's not there. So you've got to repeat all of those things. The expense is unbelievable, but for frequent flyers in particular in the healthcare system, it would be great if our entire record was there that we too could access. And I don't see why that has been made so hard by other than the vested interests who don't want it there. Thank you. And Jeanette might know more.
Jeanette will have the opportunity in a moment perhaps to respond. No other questions? Thank you so much for the very insightful questions asked this afternoon, and please join me in thanking this brilliant panel.